you for joining us tonight for Election 2020 and your healthcare. What to know before you vote. Good evening. I'm Debo, News Director at WBFO. I'm your moderator tonight. Tonight's program, though, is not presented just by WBFO. It's a partnership with Buffalo Toronto Public Media, the League of Women Voters of Buffalo Niagara, and the Health Foundation for Western and Central New York. And the topic of healthcare is actually pretty important here. According to several national surveys, healthcare is a top issue for voters in this presidential election. The COVID-19 crisis, of course, has made it clear that healthcare policy can have a wide-ranging impact really on a lot of our community. For example, the Commonwealth Fund study, although our citizens pay more than for healthcare compared to other countries, the U.S. ranks significantly lower on several measures of performance, including things like infant mortality, preventable deaths before age 75, life expectancy. There are a lot of different perspectives on this topic, and each of the presidential candidates obviously have different approaches to solving it. We're going to kick those around tonight. We'll have a great discussion with several different healthcare experts, so you can be informed on this issue, obviously, before voting takes place. Before we meet our panelists, I do want to encourage you all to submit your questions in the Q&A box on your screen during the program. Toward the back end, we will try to answer as many of them as we can. And if you're watching actually on Facebook Live, put your questions in the comments there. And now for the distinguished panel. Elizabeth Benjamin is Vice President of Health Initiatives at Community Service Society of New York. She's a co-founder of Healthcare for All New York campaign. That's a statewide coalition of 170 different organizations, all devoted to securing affordable, quality healthcare for all New Yorkers. Also on the panel tonight, Bill Hammond, Director of Health Policy at the Empire Center for Public Policy. He's a guy that basically generates a lot of data, analysis, and some commentary on the decisions made in Albany and Washington and how those decisions affect patients, providers, taxpayers, the broader economy. Laura Castle is the coordinator of Medicaid Matters New York. That's a statewide coalition of 140 different organizations. They represent the interests of New Yorkers served by the Medicaid program. She was also a member of the original New York State Medicaid redesign team. And Katie Robbins is with us. She's director of the Campaign for New York Health. That's a statewide effort advocating for universal guaranteed health care in New York State. She was formerly the executive director of Physicians for a National Health Program, New York Metro Chapter. And lastly, but not least, Melva Vischer is with us. She's an adjunct professor of community and school health at Canisius College. She retired as vice president of community health at Kaleida back in 2012, and she's worked for quite a while as an independent organizational development consultant since 2018. All of you, thanks for being here tonight and spending your time with us. Bill, I'd like to start with you. Surveys are starting to show that healthcare is really one of the most important concerns for voters this election year. What should voters know about what's at stake here in the federal election when it comes to healthcare, and especially how all of those decisions that we'd be making at the ballot box could affect healthcare access?
Well, certainly at the presidential level, they're facing a pretty stark choice in terms of alternate visions of how we should move forward. The big story of the past 10 years really has been one of paralysis and inaction in Washington, especially within Congress. When the Affordable Care Act passed in 2010, that was a pretty major change to our healthcare system, but that kind of caused a political backlash. Very soon after that, the Democrats lost the House of Representatives, and ever since then, there's been a party divide between either the one or both houses of the Congress being different from the president.
So go ahead, I'm sorry.
And for a period there, you had all Republican control, but the Republicans didn't have a coherent agenda that they wanted to pass or that they could pass. There was a series of votes, and none of their alternatives to the Affordable Care Act could get a majority. So the possibility that you would have a Democratic president and two Democratic houses of Congress, that opens the door to breaking that 10 years of inaction. The the Affordable Care Act managed to keep functioning during that time. Even though it's a very complicated law, it had a rough start, but it did bring down the uninsured rate. And in spite of some lawsuits and some executive orders that were aimed at undermining it, it has kept running. It's in need of some basic maintenance, and Congress hasn't been able to get a majority to do that maintenance.
So if it's currently running, what kind of a shift would we see if, yes, as you said, we get a Democratic president, Democratic House, Democratic Senate?
Well, I mean, the Vice President Biden has a pretty clear agenda that he's laid out. It involves, he explicitly describes it as building on the Affordable Care Act. He would expand some of the tax credits to reach more people so that it would make their insurance more affordable, and he would also create a public option, which would it would be a government-run health plan that would be kind of a safety net in addition to the various safety nets we have already. On the other hand, you have President Trump. Throughout his time, both running for president and serving as president, he has said that he will put forward a wonderful health plan, and he's yet to do so. And so I've come to the conclusion that he doesn't have a clear agenda in this area. And if he's reelected, I expect that would continue. He's done some stuff in terms of executive orders. He's done stuff that I think actually has bipartisan support, or at least he's talked about doing stuff that has bipartisan support in terms of drug prices. He wants to try and tackle that. He's got some ideas there, but he hasn't been able to get anything out of Congress, in part because he doesn't have a viable plan, but also because you have Republicans running the Senate and Democrats running the House.
Melba, I didn't want him to steal all of your thunder, but I know you've also looked at the different proposals from the different candidates out there, Joe Biden, President Trump, and you've started to look at it in terms of healthcare delivery, the idea of the provider and what this means for them. Tell me a little bit more about that. What kind of changes do you see on their landscape?
Well, thank you, Dave. I think that we need to recognize that 2020 has been a very unusual year. And for the purposes of my discussion, I'd like to define providers quite broadly, not only including those healthcare providers that provide traditional healthcare or medical services, the doctors, the hospitals, the counselors, the therapists, nurses, but also providers in terms of those that provide health and human services for our communities, because they too provide an array of healthcare services that our communities not only need, but they actually have sometimes difficulty accessing. Providers are concerned about issues that hinder their ability to provide optimal care for their patients and their clients. And in that vein, before COVID-19, we have to recognize that healthcare providers have had fiscal issues, and they have experienced economic losses and very low margins, primarily resulting from low reimbursement from their payers. Hospitals and health systems are most often amongst the largest employers in our communities as well, and we need to recognize that. The economic well-being of a hospital is actually very concerning. And as was seen when New York State was a hotspot in the spring for COVID-19, hospitals and other healthcare providers put themselves at harm's risk in order to care for the people in their communities, despite that risk. So healthcare providers continue to be concerned about not only their patients, but their employees, as well as their viability. They're concerned about patients and clients delaying accessing preventative care. Many people are very afraid of exposure to the coronavirus, so they're not seeking care in the same numbers as they have been in the past. They're also concerned about their own ability, providers are, to procure the necessary safety equipment and supplies that they need in order to treat their patients and in order to safely treat those patients, primarily due to COVID-19. The healthcare industry is a very large industry in our country. It's the largest employer in the US. However, there's great financial stress on the healthcare providers. So, yes, sorry.
A lot of what you said talked about patient access and caring for the patient, but then you mentioned COVID, and I know that hospitals have really obviously taken a financial hit because of that. Has that changed their priorities? I don't want to suggest that they're not concerned about patient care, but I've got to think with the size of the hit that they've taken, that they're starting to look at this whole conversation perhaps a little bit differently than they once did because of the economics.
The economics have certainly been of top of mind for providers. They are concerned about their longevity and their ability to quickly react to any change in the conditions in their communities. And they're concerned about their long-term viability in terms of being able to treat and care for their patients. But in addition to that, they're also concerned about their communities in terms of their employees. Providers are making the best decisions that they can. At the current state this fall, most providers are continuing to provide an array of traditional services that they have been providing all along, preventive services, et cetera. But also, they are preparing for what potentially will be a second wave of COVID. And that is creating a tremendous amount of stress on our provider community.
I imagine, and the plans that are out there, to the degree we know them, from President Trump and from Vice President Biden, do either of those, to your mind, have a bigger economic wallop on the hospitals at a time when they're vulnerable?
Frankly, the plans that have been articulated have been thin at best. I agree with Bill. The plans on the Republican side have been very difficult to even get your arms around because, in my view, there really isn't a plan.
They're vague, to say the best.
The plans from Vice President Biden have been a little bit more forthcoming, but they don't specifically address what is going to happen in our near term for our providers with respect to being able to respond appropriately and effectively to COVID-19.
All right, let's bring in Elizabeth Benjamin with the Community Service Society of New York. Elizabeth, talk about all of this from the consumer perspective. What is the current threat to ACA? How do the upcoming hearings over a new Supreme Court justice play into that? And what, Elizabeth, do you feel the consumers should really be looking at, worried about watching right around now as they go to the polls?
That's a really important question. I mean, quite honestly, the stakes couldn't be higher for consumers and especially patients in New York State. You know, the Affordable Care Act provided 23 million, with all its warts and the fact that it wasn't as well funded as it could be, did provide coverage for 23 million Americans. In New York State, we had 3 million uninsured before the Affordable Care Act was enacted. Now we only have 1 million. That's 2 million people that essentially have pretty decent coverage. I totally agree with Bill that there needs to be some serious maintenance for the Affordable Care Act. And I do believe that the Biden proposal really looks at, from the consumer perspective, what that maintenance would look like. He would increase the subsidies, the sort of the baseline that we're paying. Basically, he'd make health insurance much more affordable for consumers by, instead of saying the normal insurance plan only pays for 70% of your care, the normal insurance plan would pay for 80% of your care. That's a big difference. That's money in people's pockets. In terms of the Supreme Court decision, the way the Affordable Care Act works, it has these sort of carrot and sticks approach. The carrot is the financial assistance. That is not necessarily what's reputatively up at stake in the Supreme Court case. What's at stake is what's called the individual mandate. That's the stick. That's the requirement that in order to get financial assistance, every American has have coverage. And in exchange, insurance companies will no longer do what's called medical underwriting, which means they can no longer discriminate against you. And they have to offer certain standards of care. Like they can't cap the amount of care they provide you based on your lifetime, only do $1 million worth of coverage for a lifetime or $100,000 and so forth. So if people get really sick, their coverage will cover them. It also has financial protections, which I won't get into. What's in front of the court is with the Republican tax bill, they got rid of what the original Supreme Court case decision rested upon, which was the tax, meaning it was constitutional. The Affordable Care Act was constitutional because it used the tax of the individual mandate, and it was held to be constitutional. What this was before the Supreme Court is when the Republicans in the tax bill in 2017, they got rid of the tax penalty. In other words, if you don't have coverage, you're supposed to pay a penalty. They zeroed that out. And so the Texas and about 18 attorneys generals states basically are arguing, and now the Trump administration are saying, well, the whole Affordable Care Act has to be thrown out because there's no longer this tax, and therefore there's no individual mandate, and so the whole law should be thrown out. The Trump administration says, oh no, the whole law should just be thrown out for a few states, but they don't even clarify which states and why. So that's a little hard to understand what their actual position is. But the bottom line is this is all very fixable, even if the court, which will not really ultimately rule on this until June, but say they agree with the lower courts and say, okay, if there's no tax penalty, the whole law should be thrown out. This can be fixed by the Democrats and Vice President, then President Biden, by saying, oh, well, we could do a $5 tax. Bingo. Law is constitutional. So the stakes for patients are really high because in the olden days before the Affordable Care Act, you should know that when people try to buy coverage on their own, coverage costs $1,200 a month. Under the Affordable Care Act, it can be as low as $400 a month. And in fact, for some people it's free and some people only pay $20. It's on a sliding fee scale. But even if you have no financial help, it can be quite affordable. And that's why people have come to it in droves. We still have a bunch of people that are uninsured, and we can talk about that later about why that is, but I see you.
I hear how this is a different issue, how taxation was sort of the Supreme Court looking at it the first time around, that this time it's different. But is there anything we can learn looking back at the vote count the first time around, assuming that an Amy Coney Barrett is put on there, can we extrapolate and say, oh, they're likely to A, B, or C?
We don't know for sure. So you have Breyer, Sotomayor, and Kagan that are all going to vote for the Affordable Care Act. That's pretty much a sure thing. And you have, Thomas, Alito, I was going to say Scalia, and then we don't really know what the other three are going to do, right?
Roberts was kind of a springboard last time.
We think Roberts will stay with it because he stayed with it the first time. The case itself is pretty weak, by the way. Even conservative legal scholars think it's a fairly weak case. But these are, strange times, and this is so political. Does Judge Kavanaugh, who really, is very, he really doesn't believe it can be severed. Is that going to be important enough to him to join with Roberts? Are there going to be deals? But it is very difficult. It was looking like a 4-4 split with Amy Coney Barrett potentially casting the fifth vote. But you know what? You can never tell with the court. They often surprise you. And, it is jeopardizing coverage, not only for the 23 million people that got coverage, but for those seniors that have their donut hole for Medicaid. Their Medicare drug coverage is much better. For all of us who have young kids who are on our plans up to age 26, there are so many benefits to this law for the whole system that it would be extraordinarily, it's what even a conservative Supreme Court says they won't do, which is legislate. If they throw out the Affordable Care Act, they are in effect legislating. And so it would be against what they say they believe in. But, we don't know.
Okay. We will once it happens, but I
Yes, we will.
no real crystal ball right now.
But it is important to vote, and people should know that there is a stark difference between voting for the Trump, President Trump and the Republican Senate and Congress versus what the Democratic alternative is. And those are really, truly stark differences in this context.
And whatever happens, obviously, at the federal level, in some ways, is made moot at the state level. A lot of the federal discussion I've heard is talking about pre-existing conditions. I know, obviously, in New York State, the pre-existing conditions can't be part of the program. There's a lot in New York State that we have to take a look at in light of the possible change at the federal level. So, Katie, Laura, and Bill, I want you each to take a crack at some of the state programs. Let's start with you, Katie. Katie Robbins, Campaign for New York Health. What are we looking at the state level with the New York Health Act? And what could its passage mean for residents of the state, regardless of whatever happens, perhaps at the federal level?
Oh, thank you so much for inviting me to be part of this discussion tonight. I work with an organization, the Campaign for New York Health, which is a coalition of groups around the state who begin with the premise that healthcare is a human right and a public good. And we have been advocating for a universal guaranteed healthcare system at the state level. The bill is called the New York Health Act. And if it was passed, it would create a universal system that covers all residents and workers in New York State. The benefit package in the bill is more generous than any public or private plan that we know of. It covers hospital services, physician services, mental health, prescription drugs, reproductive health care, dental, vision, hearing, and long-term care. You get a free choice of provider. You can go to the doctor and hospital of your choice. And importantly, there's no financial barriers at the point of service. So when you show up to get healthcare, the first question would be, how are you feeling, as opposed to, how are you going to pay for this? So we're passionate about this solution. We've created a lot of momentum in building public support and support in Albany. There's a majority of assembly members who support this bill. We have nearly a majority of the Senate. And with the election coming up, or the election that will be on November 3rd, it's possible we'll see even more state senators that are in favor of this program.
Really quickly, though, the state's looking at all sorts of budget deficit.
Yeah.
Address if you can, as short as you can. I want to bring in Laura in just a second.
Absolutely.
Talk about budget. Talk about what that means for whether this moves ahead or not.
So we did have a study in 2018 from the Rand Corporation that showed that total costs for the New York Health Act would actually be less than the status quo. It would control costs in a number of ways, which I won't get into now, but I will say that's been proven over and over, study after study, that it's lower cost for most New Yorkers and for the system itself. There would be some cost for the transition, but it's almost like an investment. And let me say, maybe there has never been a more important time to look at making sure people have access to healthcare that's separate from benefits they're getting from their employer, because look what we're dealing with in the middle of this deadly pandemic, which is also an economic crisis. People lose their job, they lose their health insurance. So we're really talking about building a system that can meet the needs of New Yorkers, health needs of New Yorkers, and control costs.
So for you, budget is secondary. The goal is what you're concentrating on, and I get that. Let me bring in Laura now. Laura Castle, Medicaid Matters for New York. With that right in the name of the group, Medicaid Matters. Tell us about how this state program could affect the Medicaid program. Laura.
Hi, and thanks very much for having me. I'm so pleased to be with my colleagues this evening. Medicaid Matters New York is a statewide coalition representing the interests of people who are served by the Medicaid program. And since 2003, we've been amplifying the voices of Medicaid consumers in Albany. Our coalition membership is broad and diverse, and it includes individuals, consumer advocates, community-based organizations, community-based providers, legal services, and many more. And we all work under the same shared umbrella to bring the voice of consumers to policy and budget making when it comes to Medicaid. I'm going to start very briefly with what Medicaid is, and that is, it is a insurance program. Just like I have employer-based coverage, Medicaid is public insurance coverage for low-income people and people with disabilities. It does also provide funding to the delivery system to the providers, such hearkening back to Melva's part of the discussion about provider needs. So it is a robust driver when it comes to sustaining the both insurance coverage and the healthcare delivery system. Medicaid is the hottest topic in Albany, next to education and many of the other big debates that continue throughout the halls of Albany. There are many competing interests when it comes to Medicaid, and that is because it is a big program. It comprises over 1/3 of the state's overall budget, and it is growing. And the Cuomo administration has employed various tactics and budget remedies, if you will, over the course of his tenure to try to control Medicaid spending, or perhaps just make the numbers look a little better. And unfortunately, very little of what he has aimed to do has been done with an eye toward how consumers are impacted in the overall picture. Our job as consumer advocates has always been to continue to remind policymakers of the intent of the Medicaid program, which is to provide for what New Yorkers need to keep them well. And to remind everyone that Medicaid is not a problem. Medicaid, in fact, is a success story in New York. And it has been framed as a budget problem over the last few years because it is costly and because it is a growing program. But the reasons for that are because New York has historically done the right thing, which is to provide for a robust program, to provide for what people need, and to make sure that community-based providers and safety net hospitals and all of the providers that low-income people rely on and people in the community, people with disabilities, et cetera, rely on, are available to them. So we need to continue to tell that story. So how do we continue to write that story? What are our needs now? You know, it's already been mentioned here this evening that the coronavirus pandemic has really shown some of the weaknesses across our system, across our programs. And one of the things that we all, I think, share is an interest in making sure that through this pandemic and when we reach the other side, that we're able to reach greater equity for all. Because when it comes down to it, I think we all can agree that people should have equal access to the things that they need to keep them well.
So you're very much in the same spot as Kate, saying, let's look at this as, and I know the funding structure is different, obviously, but let's look at this like police or fire or garbage protection. This should not be a budgetary issue. This is a service we need. Finances be damned. Am I going too far?
No, absolutely. Absolutely. It's something that New Yorkers are entitled to. It's something that should remain a consistent thread throughout the state budget.
All right, I set it up for you, Bill. Bill Hammond, Empire Center for Public Policy. It's there on the tee, take a swing at it. This is not a budgetary problem. This is a service we need to take care of. Explain from your point of view why you would, I'm guessing here, say that's not the case, that it is a budgetary issue.
I mean, it definitely is a service that we all need, and it would be great if everybody could have all of it that we wanted and pay for it. The healthcare system is enormously expensive. As it is, healthcare is something like 1/3 of the state budget. If we were to move the entire healthcare system onto the state budget, which is what the New York Health Act is about, you're talking about tripling what the state spends, or tripling how much taxes it needs.
Let me ask a question about that, though. Right now, some of that cost is split with the counties. Is that what you're talking about, taking the county share and just dumping it back on the state? Or are you talking about a different increase in state spending here?
The county share would be a drop in the bucket of this. You're talking about taking all the money that employers currently spend and all the money that the state, currently spends, and to some extent all the money that the federal government currently spends on healthcare in New York, and having it flow through the state health plan. It would be hundreds of billions of dollars. It would be even if not all of that money came out of state taxes, it would be managed by the state government. And I guess I would just point out, we're in the middle of this fiscal crisis. And whatever the cause of the fiscal crisis, we have these every so often, and our tax revenues go down dramatically. And right now, we have to figure out how to pay for Medicaid, which is, let's say it's about a third of the healthcare system. Under this scenario, if we went to a single payer system, that fiscal crisis would affect the entire healthcare system, and it would be up to Albany to figure out how to fix it. I guess another thing I would point out from the point of view of providers, when the state pays providers through Medicaid in particular, it pays the lowest rates that the providers get by and large. Medicare pays a little bit better than Medicaid. Private insurance pays the best of all. If you eliminate private insurance, you're eliminating an important source of revenue for providers. We were just hearing about Medicaid. I agree, Medicaid is a very vital program, and that's part of why I think it should be managed better than it is. New York spends very heavily on Medicaid, and yet even before the coronavirus hit, it was running a deficit in the billions of dollars. So that's an example of why I'm skeptical of putting the state government in charge of all healthcare spending, because the part of the healthcare spending that it is in charge of already, namely Medicaid, has had its ups and downs, has had scandals, it has its inefficiencies and dysfunction. It does important things. A lot of people couldn't live without it, and I want to see it better managed before the state starts taking on larger responsibilities.
If this is a question that one of the other folks on the panel can address, jump on in by all means. But Bill, the argument that I've heard at the federal level in the past is, yeah, it's going to cost a lot of savings, but I'm sorry, it'll cost a lot of money, but there will be savings in the way things are provided. Does that argument hold any water with you here to minimize the effect on the budget if we go with this Medicaid plan at the state level?
There would probably be some savings on the administrative side. If you have one health plan instead of dozens of health plans, there's a lot of paperwork that you can save.
But you would say it's not enough to balance the two.
Well, you're talking about at the same time you save that money, you are expanding coverage, so you're covering more people, that adds costs. I'm losing the thread of my thought here. There are costs that go along, there are costs that go with expanding the system. And then you also have to, where would the savings come from beyond the administrative savings? The question is, would you pay the providers less in order to balance your budget?
All right. Before we move on, I want to give Laura or Katie or Elizabeth or Melba a chance to jump in on that last point.
Just on the last point, the savings in a single payer system are, of course, the administration, but also being able to bargain for the cost of drugs and medical equipment, very big savings there. It does not have to be balanced on the back of providers. You could raise the reimbursements to Medicaid providers to a higher level and still see those savings from administration and the prescription drug and medical device bulk purchasing.
Okay. Let's move on now to really what could be. We've talked about the federal program that could come in depending on who the president is. We've talked a little bit about the state program, but let's just dream for a second. What's missing from the platforms of both presidential candidates? Are there some policy options out there that are just not on the table that, in the opinion of any one of you on the panel here, could really bring more people in, create a more equitable approach, provide more access to healthcare? Katie Robbins, let's start with you. Campaign for New York Health.
We have been really passionate about advocating for a single payer improved Medicare for all model. And on the federal level, we don't see that on the table in terms of the candidates, but I do think that we can say there's a right direction and a wrong direction to healthcare reform. We've used principles around the right to healthcare to evaluate these proposals. Is it universal? Will everyone be covered, right? How many people are we leaving out in the status quo? Nationally, about 30 million. So we have a lot of room to do to improve there? And how about other areas around equity? We know that especially during this pandemic, we've seen so many of our 2020, what can I say? We've seen so many of the people who've suffered the most are low-income folks, people who are from Black and Brown communities. And this would be a huge lift to make sure that everybody is getting the same high quality standard of care, regardless of, if you're walking in with an insurance card that's from your private insurer, from your employer, or Medicaid, right? So we think that there's a lot of room to do to just look at improving equity and universality in moving this in the right direction. I know Elizabeth can talk a lot more about the kind of incremental reforms that can move us in the right direction. And we continue to be very, very passionate about the vision of making healthcare a right and pursuing reforms that really meet the principles to the right to healthcare.
So, and I'll get to Elizabeth in a second, I promise. But for you, the dream would be to have something like this New York plan on the federal level. What is the best thing that's not out there now as far as you're concerned?
The best thing that's not, well, of course, the Medicare for All bill that's been pushed by Jayapal and in the House and Senator Sanders remains one of the most important things we could do. They have a similar bill that's like essentially an emergency guaranteed healthcare act that for this crisis would make sure that every single person in this country was able to access care without fear of how much it will cost. And I don't have to tell you, people are getting huge bills for the treatment of COVID, huge bills just for the testing, right? That's deterring people from getting the care they need and absolutely exacerbating the effects of this pandemic. So passing the Emergency Guaranteed Healthcare Act would be a huge step in the right direction on the federal level on our way to Medicare for All.
All right, Elizabeth Benjamin now, Community Service Society of New York.
Sure,
Again, hi, dream with me.
Sure. I think there. Oh, I'm sorry, Dave. Go ahead.
No, I'm just saying dream with me. What would you really love to see that is not being proposed by anyone at the federal level? If you were whispering in Joe Biden or Donald Trump's ear, what would you say?
Well, the word I would be whispering is immigrant coverage, because honestly, that is the whole, and it's sort of a third rail. People will, neither. Tracing back to the days when President Obama was giving his State of the Union message and Joe Wilson, screamed, "You lie," at him. For those that remember that, when, essentially immigrants who are, unauthorized immigrants basically do not have access to health care. They can go to, community health clinics. They can be treated on an emergency basis in hospitals, but that's a piecemeal system. And when you do have a global pandemic, it probably makes sense to have some form of coverage for every single resident in this country, regardless of immigration status. So I think that would be the one thing that neither candidate is probably going to embrace in the next month. But I think we really have to think about, and that's my big dream, after, somehow magically figuring out a way to have a less piecemeal system. I think another dream that I have is, if we cannot have just, overnight Medicare for all, which we, my own agency has endorsed, but I see it being a very complicated path to getting there. But there are some glide paths that we should adopt as a country. And I think Joe Biden would be interested in it. And I think Donald Trump wouldn't be. For example, lowering the age of Medicare to 55. If you don't have an offer of job-based coverage, offering Medicare for people, lowering that age limit to Medicare would really do two things. Number one, it would make the Medicare trust fund more solvent because you have healthier people and in it, and so you have a healthier risk pool. But number two, I think it would really help a lot of people who are older and having a hard time getting good jobs and may be recently out of work due to the COVID recession and may have a hard time getting good jobs with, full employer-sponsored coverage. I think there's some other things we could do. Let states experiment. If New York wants to do a New York Health Act, let them take the, the Affordable Care Act money, the Medicare money, and the Medicaid money, and try to go for it. Or maybe, maybe Delaware will do it, a smaller state. I think there's, we really have to think, and Bill hit this right out of the park. We have to improve the financial assistance that is offered under the Affordable Care Act. there is a healthcare affordability crisis that affects patients and providers. Providers are stuck holding the bill with these large deductible plans that everybody keeps lurching to because they're kind of crammed down into it through the lack of proper funding through the Affordable Care Act. We need to make the Affordable Care Act offer better coverage by improving that financial assistance and the cost sharing that patients are suffering under. So I think there's a lot to do, and there's a lot of incremental stuff we could build on our own basic health plan or our essential plan here in New York State, expand that income limit from $25,000 a year to $35,000 a year, and have really inexpensive $50 coverage a month for those folks. It's super comprehensive, no deductible. I think that would be amazing. So I think the states, we live in a federalist, country, and if we can't do it, overnight, Medicare for all, and kind of clean up the sort of chaos of our healthcare system, I think we should really look more deeply about and provide the resources for states to really experiment in bold ways.
All right. I feel a little bit like Chris Wallace, although I think I've got a much more polite group assembled here. No offense meant. But in any debate, when someone mentions a name, you have to turn to the other guy and say, well, your response. Bill, she said, she called you out there. Although in this case, the two of you are in agreement. But I wanted to get some comment from you because she mentioned your thoughts rather than have her paraphrase your thoughts. Jump on in for me.
I mean, my sort of philosophy about things, especially with respect to healthcare, is to move incrementally, not to try to do big, giant things. And I think there's two reasons for that. One is you have a limited amount of political capital to spend. And so if you want to use that political capital in the most effective way you can, why not focus on the most important things that need to get done? I would argue that if you want universal coverage, in New York, we're about 5% of the population away from universal coverage. Put your emphasis on the 5% who need coverage, and let the other 95% more or less have the coverage that they have now. Certainly, I would argue, we don't want the state to step in and start providing coverage to the wealthiest members of society. They should be responsible for their own coverage, as is most of the middle class can also take responsibility for their own coverage when they have jobs.
All right. Okay, go ahead, Bill, and then I want to bring in the rest before we move on to listener questions, your questions.
I mean, I just very quickly, I agree there's a right to health care. I agree there's also a right to food, and there's also a right to shelter. Our approach as a society to enforce or to respect the right to food and shelter is not to have food stamps for all or public housing for all. The government intervenes on behalf of the people who can't supply their own food and their own housing. And I think that's the basic approach we should take with healthcare.
All right, Melva, I don't want to put you on the spot, but we haven't heard from you in a while. I'm betting that you can push back a little bit against what Bill just said.
Well, I actually agree with both Bill and Elizabeth to some degree. I think that it is important to see where we are now as New Yorkers. Bill is correct. Recent studies have shown that 95% of New Yorkers have access to some type of health coverage. And I think an incremental approach is not only necessary, but it's probably the most viable approach at this particular time for us as New Yorkers. So to focus on those folks that are not covered seems to make a lot of sense to me. I think about the types of coverage that are universal in other industrialized countries, and I think about some of the issues that those countries still deal with under universal approach. So I'm a little bit more cautious and conservative, even though I too believe that healthcare should be a right. It is not a privilege of individuals who are wealthy enough to be able to afford it.
All right, Laura Castle, Medicaid Matters New York, jump on in.
Thanks, I'd be happy to. I agree as well that healthcare, access to healthcare should be a human right. I think we can all agree on that. But I also think that, and I agree that the way to, I think Elizabeth used the word glide path. I think we need to work towards a universal coverage program, or you know, getting to that goal through incremental steps. And if that means you know, covering the uninsured, the remaining uninsured, if that means building a better system, building on the successes of the Medicaid program. You know, as hearkening to what Bill said, there's a lot of things that could be fixed in the Medicaid program. We all, I think, in this industry continue to have jobs because of all the things that we would fix in Medicaid and in all the systems. And one of those, I think, is certainly financing and making sure that, you know, as this discussion has related to the budget issues, making sure that money is being spent appropriately in the Medicaid program. Is it actually in the delivery system going towards the providers and the facilities that actually do provide coverage services to people who are uninsured and low-income people on Medicaid? You know, making sure that things are right-sized or corrected in a way that allows people to continue to have access while also making improvements. So I absolutely agree. There are things that we can be building on. And I also, you know, perhaps not for this time, and I know we've got some time constraints here. I think there's also a lot to continue to discuss around, is the New York Health Act the right thing? Many of us believe that it is, and many of us also believe there are incremental ways to get there. There's a lot of discussion to be had around that.
All right. Toward the end of the program, what I'll probably do then is have each of you give a reference or some way where people can join the debate beyond these time constraints. We would like to just in a moment or two start taking questions from the Facebook audience. If you're out there and you can type in a question, we've got a few that are starting to sprinkle in, but we can always use some more. Just put your comment on the screen here and hopefully we will get to it. We'd love to have you aboard that way. Just a little bit more time before we go to those questions though, and I want to make sure I'm giving everyone sort of a chance in the batting order here. Katie, you're up now.
Great. I'm sorry. So I should be fielding the questions from the.
No. I'll get to an audience question in a moment. But
Oh, I see. Got it.
I had everyone else react to what had been said prior, and I want to make sure I'm giving you a chance to do that too.
Thank you so much. It's just so great to have this kind of dialogue. And I want to make sure folks know that the Campaign for New York Health really sees this as, you know, to get to the goal of truly universal guaranteed healthcare, we really need a people's movement in New York State. The gains that we've made in healthcare historically have been because people really demanded it. So I encourage you to check out our website and sign up to get involved at nyhcampaign.org.
Okay. And again, at the end of the program, we'll have each of you give out those kind of references if people want to learn a little bit more. We are starting to get some questions in from the audience. The first one here is for you, Elizabeth. Elizabeth Benjamin with the Community Service Society of New York. What are the key barriers, Facebook person asked, what are the key barriers to a comprehensive public health care system in the United States? Elizabeth.
Wow. I would say, you know, quite frankly, the moneyed interests that exists in our healthcare system. You know, there are just so many, and you know, and everyone's kind of guilty as charged here. You know, the insurance companies, the pharmacy companies, the medical device companies, you know, even doctors, you know, I mean, you know, the doctors that are housekeeping in Patagonia that are the fancy, you know, surgeons or no, I think actually the poor primary care doctors really get the short end of the stick in this system and probably, you know, are not a barrier. In fact, I believe that the Academy of Primary Care Physicians has actually endorsed single payer or a single payer proposal or some of those groups. But also the hospital industry has no interest in a single payer system, a universal health coverage system. So, you know, it's just a very, very big moneyed system, and it takes an enormous part of our GDP. I'm sure Bill could tell us exactly what percentage, but you know, it's probably around 20%. And it you know, when you have that much money flowing in the system, there's a lot of opposition to anything changing with the status quo.
All right.
That's why I think all of us have been talking about glide paths and incremental and how to get there. And that's, you know, it's just money in our system, and money in lobbying, you know, and money in the political system too has made it so difficult to get there.
All right. Another one just coming in from Facebook now. And I'm not sure who specifically this should be directed to, so maybe we'll let you all have a crack at it. Studies have shown that 50% of insured folks who are covered by employers are afraid to access their health care for fear of debt. Please address. And Elizabeth, you're on the screen right now, so we'll start with you.
I mean, we just did a study right now, the non-profit charitable hospitals, of which every single hospital in New York State is a non-profit charity. Altogether, they have 40,000 lawsuits against their patients right now. The outrage of all this is the incredible disparities, because when you look at a place like Syracuse, 41% of people in communities of color have medical debt, and it's only 12% of white folks, their white counterparts. So this issue of medical debt is very pernicious. A lot of people have it, you know, regardless of race. But on top of that, it really does have a disparate impact on people of color.
All right, Katie.
So
Katie, I see you're nodding your head.
Yeah,
Chime on in.
We've talked to thousands of New Yorkers, and the issue is that people who have private health insurance cannot afford to use it. That's why we can't simply just focus on covering the folks who are uninsured, which we want to do, but we want to make sure that people who have coverage are able to access care. I know people who are listening know the feeling of worrying about if they're going to be able to cover the copay or the deductible that goes along with their private insurance plans. And that is really one of the big issues that will be resolved by moving to a single payer system or the New York Health Act.
All right, Lara or Melba, do you want in on this one?
I'd just like to add that I agree. I think studies have shown for the last many years with the shift of employer-based health insurance to a large extent to the high deductible plans, individuals and families have really been burdened by debt. And the number one cause of bankruptcy in our country has been related to medical debt. So I think that is absolutely an issue. I don't have a good solution, at least not in the short term or the near term. However, I do think it is important to recognize that families are struggling with that debt.
there is actually, I'm sorry, Mel, there is an actual bill in Albany called the Patient Medical Debt Protection Act that would provide a lot of protection for patients in medical debt. I didn't mean to jump in, but there is a bill there.
Bill, I thought I heard you
appreciate
there
that.
too. Yeah, I'm not sure who I heard trying to chime in. Was that you, Bill?
No.
Okay. All right, we have another one coming in now. This off Facebook, and this again is for Katie. How will pre-existing conditions be handled in the New York Health Act as if costs will be lower than the status quo? That seems like it will impact on which medication or equipment you have access to. Sounds like this person is asking a little bit about rationing. Katie, go ahead.
I see. So of course, pre-existing conditions are covered in the New York Health Plan. And when we look at comparable systems, outcomes for chronic health conditions and many other metrics for quality of healthcare are so much higher than what we have in this state and in this country. So actually health outcomes are expected to improve when people have consistent access to high quality healthcare.
All right, another one came in just now. Melba, this one's for you. What do you feel are the challenges and opportunities for federally qualified health centers, FQHCs? Describe what they are a little bit, and then talk to me about the difference you feel they could make.
Sure. The federally qualified health centers, or FQHCs, they are actually a safety net provider. They are a primary care provider that offers expanded services. So in addition to primary care, most of them provide dental services, pharmacy, counseling services, mental health counseling, as well as substance abuse counseling, laboratory, on site. So it's like a one-stop shopping facility.
It almost sounds like you're talking about the old HMO model. Like in Buffalo, I think of healthcare plan where they have these clinics and people would just kind of go there and get everything from a single provider, no?
Well, not quite. The old HMO model is a similar model. The difference here is that the FQHCs are actually subsidized by the federal government, and they are subsidized to provide care for the uninsured. Therefore, their fees are actually based on a sliding fee scale that considers the family size as well as annual income. So they don't have a fee structure that's similar to most private insurance fee structures.
And do we have these centers now, or need there be something in legislation to allow it?
There are a number of such centers that are located primarily in low-income communities in not only most of our major cities within the state, including Buffalo, Rochester, Niagara Falls, but there are also a few in rural areas. Expansion of FQHCs would certainly help with respect to provider shortages, particularly in our rural areas, should that be possible. And there is a whole host of regulation and standards around FQHCs in terms of who can actually start an FQHC. There's a number of standards that must be met in order to ensure that the care that is provided is not only comprehensive, but it is of a high quality.
And are they fully federal funded? How do they get their money? Do they just provide care and then
They're funded. They're funded. They actually have, similar to most of our providers, they have a mixture of funding. They're not solely organized for the uninsured, but they do get subsidized in order to provide care for the uninsured and individuals who cannot afford to pay for their own care. But they, generally speaking, anyone, you and I can go to an FQHC and receive services should we choose to. They're open to everyone. They are not in every community, but there are a number of them. And in the recent past, there was a big expansion of FQHCs here in the Western New York area, as well as other communities across the state.
All right. I think it was Elizabeth. Someone said earlier that there's so much more on this topic that we can't get to in the amount of time left here. So with that in mind, I want to just quickly run down the panel and ask for resources or ways to access the kind of information that each one of you have been providing here. Earlier, I think, Katie, you already mentioned your website. We'll give you another chance to do that. But let's start with Bill. What resource would you want people to take a look at in the closing minutes here?
Well, I'll give a plug to my own organization, the Empire Center, empire.center.org. I blog a lot of data and facts and analysis about the healthcare system. It's not going to have a lot of politics. We're a nonpartisan organization, so it's not going to have recommendations on candidates or anything like that. And I'm a fan of the Kaiser Family Foundation. It's another great source of information.
All right, Melva, you're up next. What resource would you like to refer to the audience?
I think there are a number of resources as well. I think Kaiser Family Foundation is stellar and certainly a very well-respected resource, very accessible through the internet. And I wouldn't necessarily discount some of our federal resources. The CDC, the US Census Bureau has information, our state government through health.newyork.gov as well, which is run by our state health department. So I would look to both the private as well as the public sector with respect to access to information. And I would certainly applaud the other panelists here tonight, because I've learned something tonight, and I'm sure many of the audience participants have learned something as well. So I do appreciate them.
I want to try and get everyone in. Laura Castle, you're up next.
Well, thanks. I would, of course, invite people to visit the Medicaid Matters website at medicaidmattersny.org. We also rely on some national partners to provide resources and assistance, including Community Catalyst, Families USA, and the Center on Budget and Policy Priorities. Those are three I would shout out.
All right, Katie, I think you gave yours earlier, but quickly, hit that website again.
You can sign up with the Campaign for New York Health at nyhcampaign.org.
And Elizabeth, did I get you yet? I don't think I did. Go ahead.
You Did not. I would, the Healthcare for All New York campaign has a really active blog and website. I would look at that. I'd also look at the We the Patients. They're on Facebook, Twitter, Instagram, super active if you want to engage as patients about what's right, what's wrong about the healthcare system. And I would second Melva on going to the New York, if you're looking for coverage, go to the New York State of Health website. They have really, that's the way to get health coverage in New York State. And, we can help you sign up. So go for it.
All right, very good. Thank you all. Everyone, I'm so glad you joined tonight. Good array of opinions here, a lot of good information. Our final message tonight, of course, is to make sure you exercise your right to vote. 2 days from now, October 9th, is the final day to register to vote.
We're done.
You can visit 411.org to register, find your ballot, or check the registration status. Thanks for tuning in, and good night.